So hello everyone, I hope you can hear me.
Absolutely, Jose. You are
This is,
very loud.
thanks for this. So it's obviously a very important meeting to check our preparedness to meet the challenge that we face today with COVID-19. First of all, the most worrying aspect of this whole episode is that we are unsure as to where we are standing. We are unsure as to whether the trend is actually rising, the number of cases are rising, or have we plateaued off? We are very uncertain, and we really cannot tell, and nobody can really predict as to which way we are going. And if the worst is yet to come, we need to be prepared to face it. And I'm sure many of us work in corporate setups. By what we understand from the governmental directives, we are planning, at least in Bangalore, to send them to one single center, which is the Rajiv Gandhi Center for care of patients with COVID. However, if indeed we are yet to face the worst, it is quite possible that we will be overwhelmed with cases, and one center will obviously not be able to provide attention either on an outpatient basis nor inpatient basis. And most of all, if there are patients who get desperately ill, who require intensive care, Rajiv Gandhi Institute on its own will not be able to do it. And that's where I feel we must all have a plan as to what we can contribute and in what way we can contribute to the community by offering care to patients who may become sick, particularly with critically ill patients. So as we speak, the numbers are rising, except in China, where they seem to have seen the worst of it. But everywhere else in the world, the numbers are rising with over 139,000 cases as we speak. And there have been over 5,000 deaths all over the world, particularly in China, in Italy, and also in Iran as well. Although currently in India, we have not identified, I must say, there may be a lot of cases, but we have identified only 81 cases. Kerala tops the list with 19. But as I mentioned, one of the problems is the true identification of the truly infected patients. From the Chinese experience, we know that it took them a very long time before they were able to really get a hang of the situation as to what the numbers really were. For the first few weeks, there was hardly any information as to precisely what's going on, how many cases they were having. And that made them ill-prepared when the worst came to them. And this is being experienced by other countries in the world as well. Now, we have the experience from China, we have the experience from Iran and Italy, and now is the time for us to really step up things and prepare ourselves, equip ourselves to face the worst. So let us look at a very brief evaluation of what this virus is and how it spreads and so on. I'm sure most of you are already well versed with it. The worst problem with coronavirus is that it is a RNA virus, and the fact that is most concerning is that it has a very high potential for transmission. It is highly infectious compared to the SARS epidemic. It is much more transmissible compared to the SARS virus. And that makes it extremely concerning. You go by what's called R0 or R0, which means the number of patients a single patient with infection can transmit the disease. And in case of COVID-19 disease, that number is close to 2 to 3, which means each patient with COVID infection can transmit it to at least 2 to 3 people. And not only that, there are some super spreaders or super shedders who can spread the disease to as many as 15 to 20, which has been the experience with China and Italy as well. So there are some among us who have a tendency to spread the infection far more wider than others do, which is again a major problem. So the question arises, when do you suspect that somebody has coronavirus disease or COVID disease? You may come across patients in your OPD or in your emergency department, and the criteria for suspicion have been very clearly laid out. The first and most important point is a person with suggestive symptoms, which includes fever with respiratory symptoms, including cough, breathlessness. These are the three most common symptoms associated with COVID disease. And if you have these symptoms, and if there is an epidemiological link is a person with whom the subject that you evaluate has been in contact with, or a person who comes from a country which has witnessed an outbreak, or a patient with whom the subject has been in close contact with, who has a high suspicion of the disease in the last 14 days. So these are categories of patients who carry a high index of suspicion. And it's very important that they must be triaged adequately, and each of our hospitals should have a pathway as to what exactly we are going to do with suspects who have the cloud of suspicion hanging over them. And we will come to that a little later as to how to triage them and how to transfer them to a facility which the government has directed us to do, or perhaps carry on with care in our own hospital as well. We will just briefly go through also some of the important precautions that you must take as healthcare givers, especially in the ICU when we have contact with patients who have suspected COVID disease. So obviously in public, we need to be very careful to maintain what's called social distance. 6 feet is what is suggested from people. And when you are coughing, sneezing, talking, etc., you must take precautions to make sure that you are well away from people who might be infected, potentially infected. A mask may protect to some extent, but most of the understanding from all around the world is that for masks to be truly effective, the perpetrator of the disease should also be wearing a mask, not only those who are exposed to the infection. So masks may protect you to some extent, but it's important that the infected subjects also wear a mask, which you may not always be assured of. More importantly, when you come across sick patients who are capable of producing droplets or aerosols, what are the precautions that you must take, particularly in an ICU setting? The main mode of transmission of COVID disease is through droplets. When you cough, sneeze, or speak, droplets of saliva or secretions might actually disperse in the atmosphere. And if you are within the critical distance, you're likely to be deposited with the organism and get infected. That's the main mode of spread, but there is some doubt as to whether the infection can spread as aerosols as well, such as may happen during suctioning, high flow oxygen, NIV, and so on, which we will again discuss in detail a little later on. So droplets as well as aerosol spread may happen. And the third very important mode of transmission is through fomites, deposits of secretions of viruses on metal surfaces, wooden surfaces, plastic surfaces. They can actually survive. The virus can survive for an extended period of time, lasting up to a week or more. And when you touch these surfaces and inadvertently touch your face, that's when transmission may happen. And that's one of the things which we must be very careful about. That's why the emphasis on frequent hand washing with soap and water. Alcohol rub, 60% or more, may be partially effective, but it is probably not 100% effective is what the experience and available information suggests. So soap and water, alcohol, frequent hand rub to prevent possible fomite transmission. And of course, it's easy to say, not easy to practice, not touching your face. In fact, I've been trying my best not to touch my face, but very often I find that I slowly sort of drift away and touch my face for various reasons. So it's perhaps not always possible to take these precautions. So that's the importance of hand washing. So what are the pieces of personal protective equipment that you should focus on in an ICU setting, which is a very highly likely atmosphere to produce droplets as well as aerosols? Water-resistant gowns are mandatory. Gloves, latex gloves, with the gown well tucked into the glove. Surgical masks may be okay, but it is probably advisable to use N95 masks instead of surgical masks if there is a fear of possible aerosol spread. N95 masks, very important to fit test them. You should fit it in such a way that it tightly fits around your nose. And when you breathe out, there should be no leak around the mask. If there is a leak around the mask, obviously you can get infected through that. So it should be fit tested by your buddy to ensure that there is no leak around the mask. You should obviously wear a cap. And one of the other important things, which I don't know how many of our hospitals have this, is to use the face shield. The face shield or goggles is what they recommend. I would reckon that face shields will be a much more effective way of protection than goggles. I'm not sure if our hospitals are equipped with these. And at a time like this, when even surgical masks are hard to find, I think we should inquire and equip ourselves suitably to make sure that we have sufficient numbers of that. So visor for face protection or goggles, in addition to the water-resistant gown, gloves, N95 mask, cap, and shoe covers that I already mentioned. Now the next question is, how do we accommodate patients who might come to us for whatever reasons? They may have slipped through the net, they may have been transferred from elsewhere, or they may have come to your emergency department and they are not in a condition to be transferred elsewhere. In those situations, you may be forced to take them, or a time will come if the worst is yet to come, and if you are overwhelmed with cases in the next few weeks, we need to be prepared anyway. So just to roughly calculate, you must have a segregated area within the hospital where you're going to handle these patients, which will include a common area for patients who are stable, which hopefully we won't have to do. Hopefully they can go to public hospitals, which is what the government is directed as well. But you should have, I feel, as a reserve, some ICU beds as well, depending on your ICU strength, and earmark them for possible COVID patients who might need ventilation in your setting. And it depends on how many beds you have and how many you can spare, but it is very important to plan now itself and equip yourself. So I just made a rough calculation. If you are planning for, say, 15 to 20 patients, I'm talking about the worst case scenario in a big hospital, 15 to 20 patients on ventilation or on NIV or high flow nasal oxygen requiring intensive care. If you have 3 shifts of nurses, 2 doctor visits, 1 ancillary staff visit, and if you calculate for 14 days, you would require roughly about 2,000 pieces of this PPE. So that's a very high number. I have asked my own hospital administration to try to get it for us. I don't know how easy or difficult it is going to be, but if we prepare ourselves early, perhaps we can do that early enough. Now, there are certain precautions that we need to take in ICU, particularly apart from the use of personal protective equipment. This is with regard to the kind of management strategy that we follow in the ICU. First of all, should we use therapeutic interventions that carry a high risk of droplets or aerosols? These include the use of high flow nasal oxygen, firstly, the use of non-invasive ventilation, which many experts in the field, particularly after the SARS epidemic, they suggest strongly that you shouldn't use an IV because two reasons. Firstly, there is a very high incidence of droplet and aerosol spread from an IV use. And secondly, it tends to delay things to the point that you reach a stage of requiring emergency intubation with adverse consequences to the patient and to the caregivers as well, because in an emergency, you may not be adequately prepared to protect yourself, and you may have to do a laryngoscopy quickly, do suctioning quickly, and get exposed in the meantime. So perhaps we should reconsider the use of non-invasive ventilation. High flow nasal cannula as well would come into this category because of the aerosol generation that's associated with its use. Some guidelines also suggest nebulization is bad, but other guidelines suggest that it is not particularly harmful. So that is something which we need to debate and do a little more research on. So the next question would be, as I mentioned previously, as to how to triage your patients. If your patient gives a suspicious history of contact with an epidemiological link, having visited a country or been in contact with a person diagnosed to have or suspect to have COVID, then the triage should include, first question will be, is the patient stable and can the patient be managed at home? Second question is the patient sick and needs hospitalization? If the patient is sick and he needs hospitalization, currently the government directive is that we should send them to one center. But as I mentioned, if things take a turn for the worse, we will have to accept them as well, because one institution will not be handled the number of cases we come across. And the government has also come out today with some guidelines for testing as to who should qualify for testing. We need to read through that and abide by that as well. And as I mentioned, if a situation arises wherein we get lots of sick patients and the system gets overwhelmed, we obviously will have to take them, admit them to our ICUs as well. And that's what we are trying to deliberate and prepare ourselves today. So as I mentioned, it's a very unclear situation as to which way we are heading. The Chinese seem to have been able to contain the worst onslaught in the last few days. Their numbers have come down quite dramatically, so it would seem. But the way they enforced is perhaps not possible in a more democratic setup like ours, and with the kind of population that we have in our country and in many other countries as well. They have also been facing this with very high number of movement of people, very frequent contact. So we may not be able to enforce. So that's the reason why the Chinese model may not really apply to us, and we may need to adapt ourselves to the situation that we find ourselves in. Of course, several steps have been taken by the government as of today, including the cancellation of mass gatherings, shutdown of movies, shopping, big shopping malls, etc. So these are essential steps, and hopefully they will work for us. So these are very important initial steps. The other important thing that I mentioned at the start is the numbers that we get today will be a gross underestimate of what is actually happening. If we say we have identified 81 cases today, it is probably only the tip of the iceberg that we are seeing. There may be hundreds, maybe even thousands of cases. That is precisely what the Chinese realized, much to their much to their discomfiture and much to their level of unpreparedness as well. So with those words, I will leave it open to the House to carry out further discussion on this topic. Thank you.
Yeah, thank you very much, Jose. I think it was very clear and lucid. So I think we will open the House for maybe a few questions, maybe for 5 to 10 minutes, and then we'll go to the second talk, following which, when the panel starts, we'll get you back into the panel, Jose.
Sure.
Would that be okay, Jose?
Yeah, that'll be fine, Pradeep. Thanks.
So we'll pass on the mic to people, and whoever has questions, you can address that, Jose.
Okay, thanks.
Hey, Guru.
Hello.
First of all, that just
charges there.
We as healthcare providers, how do we take care of ourselves as we are not sure which patient is carrying this infection? How best we can take care of ourselves so that we can help the society?
Yeah, what we mean to say is that patients who are who have symptoms suggestive of the disease, or whom you may suspect to have, whom you see in the OPDs, etc.
Exactly.
The protocol that we have made for ourselves is, as soon as they walk into the hospital, we ask them questions. There's a questionnaire that they need to answer. First is whether they have traveled to a country which has witnessed an outbreak. Secondly, have they been in contact with a person who has traveled to this country? Third, do they have symptoms which are suggestive, including fever, cough, sore throat, breathlessness? And if they have any of these criteria, if they fulfill any of these criteria, we have already started the process. We take them to a triage room and get more details, and then consider possible further evaluation, including testing and including transfer to Rajiv Gandhi Hospital if appropriate. So that's the current plan, current protocol that we follow.
Secondly, in our country, people do not accept. For example, I had a patient from Germany 8 days ago, came to me with a history of fever, cough. He didn't have breathlessness. He had come to Bangalore a week ago.
Yes.
And then he developed these symptoms.
Yes.
The moment we say that you have to get it tested, they deny. They do not accept. So how to go about with that? Whom should we approach, or whom should we tell this message so that we can curtail the infection?
I think I'm sure others will also be able to answer this question. But what I would think is we must report this to the health authority and enable them to track this person, because obviously we can't force people against their will. But we must report it to the state authority, who should take the initiative to track down the person and perhaps even enforce it. I think there is some law that exists to enforce isolation in a case like this, where there is strong suspicion of the disease. I'm sure others will also be able to contribute to this.
Thank you. Thank you.
Sir, can you hear me, sir?
I can, Ajay.
So you mean to say that in your hospital, so just want to know what precautions have you done at your hospital level and at your ICU level? So you mean to say that any symptomatic patient coming to respiratory symptoms, so you don't admit in your hospital, in the wards? Less sicker patients, it doesn't require any ICU admission?
Patients who are not sick, who are relatively stable, who require admission.
Who doesn't require ICU, do you admit in the ward?
So far, we haven't encountered anybody with these typical symptoms or with history of contact. But the plan is...
Doesn't require ICU?
Yeah, yeah. The plan is if they are stable, if they are well, we would ask them to stay home, and if required, we will ask them to get tested according to the criteria that the government has already mentioned. If they are unwell and requiring, or looks like they might worsen to the point that they will require critical care, at this moment we are not admitting. We would transfer them to the Rajiv Gandhi Institute as the government has directed us to do. But as I mentioned, that is only for the time being. We don't know what is going to happen tomorrow. The government policy may change. And in fact, our chairman has also suggested to the government along the lines of what the plan should be in terms of if shit hits the fan, so to say, how to handle it. And we are actually earmarking an area within our hospital for inpatient care and possible ICU care as well in the worst case scenario. I think we should all be looking at that possibility at this point.
So you mean to say that the symptomatic patients who does not require ICU care, you are quarantining them at their home, you mean to say?
That is what we are planning to do.
At their home. And you need to check the COVID testing as well.
Today, as we saw today, the government has directed as to who would be a candidate for testing, isn't it? I just briefly went through those, the directives of the government as of today. So we'll have to abide by them. And if they really require testing, we should get them tested. And testing, of course, when you draw up the swabs from the throat and from the nasopharynx, what we have decided is the operator, whoever does it, should wear an N95 mask first. And secondly, we have also identified a negative pressure room to prevent aerosol spread, which is, I think, a sensible precaution, although the possibility of aerosol spread is, it may not really exist. So yeah, that's the way we have planned it out.
No, my understanding is that it's predominantly it's a droplet precaution, droplet spread. So actually, you know, the only those patients who is having an airborne spread, those are the patients who require negative pressure isolation. So do you really think, you know, the droplet spread will require a negative pressure isolation?
Droplet alone may not require, but you know, nobody knows for sure if there is aerosol transmission for sure or not. That is pretty much unknown. Droplet, yes, there is no doubt about it. Aerosol, there's a question mark there. But when you do a procedure which involves a high risk of aerosol generation, as in testing with a pharyngeal or nasopharyngeal swab, the patient may cough and sneeze and all that, which might produce a very thick aerosol, which might spread across several rooms. So in that instance, if you are doing testing, we are planning to do it. We in fact have earmarked a negative pressure area to do the swabbing particularly. And the operator will wear an N95 mask as well, as I mentioned.
Thank you.
But I'll just add one more thing, Jose. As days are going by, we have to realize that we need to concentrate more on the local transmission also and not restrict ourselves only to those patients who have come from abroad or corona infected areas.
Very, very, very important, Karthik. I really agree with you, totally agree with you there. Over time, we will get native transmission of the disease. And it may be happening even now, we are unaware. So as you very rightly pointed out, sooner or later, we will get patients who had no obvious contact. It's been happening already in Italy, for instance.
Request the people who are logged in, if you can get to the chat and type your question, you can unmute and ask the questions. I think there are 35 people who have logged in. So 41 have logged in. So any of you have questions, just go to the chat and start chatting, then you can unmute. So you will get the question and we'll direct it to Jose.
They can speak over the mic as well, isn't it? Is that possible?
They can unmute and speak as well. You can unmute and speak as well.
Unmute and speak.
Hello, sir. Good evening, Dr. Baswaraj.
Hi, Baswaraj. Hi.
Sir, wanted to know today's government decision that are we supposed to do the test in private hospitals? Or are we supposed to admit the patients in private hospitals? Or are we supposed to send them all to the nodal centers where the government has appointed?
From my reading, I just briefly went through those, somebody had posted on WhatsApp. It looks like if they need to be admitted, they would need to be sent to the designated center. That's what it says. So as things stand today, we may not admit patients or suspected patients in our hospital. Testing, I think we take the sample and we send them across to the designated testing centers. That's my understanding.
I think Dr. Devi Shetty and Dr. Ravindra were there in the discussion. I think they have proposed to the government that all of them should be sending it to them, but so that it can be contained in a particular area of Bangalore.
Yes.
But on the other hand, there are many patients who doesn't want to go to RGICD, and then they say that either they have not been exposed or they have not been given appropriate travel history and still may be positive, and they're roaming around in the private hospitals also. So hence, in these borderline patients, what we should do now and what the government stands, and do we have to follow the government stance, or do we have to have our private hospital? We should go forward and then check all these patients in hospitals wherever they come, admit. Just want to know what you want to say, sir.
As things stand today, I think we are directed to transfer them to the designated center, Rajiv Gandhi Institute in our case in Bangalore. Testing samples, I think we can draw ourselves and send it to the lab. That we have already been doing. We are not doing the test in our hospital, of course.
Okay, so since we are sending everybody to RGICD or BMCRI, as of now, private hospitals, I mean, what all precautions we need to take only when the government gives us direction that you admit in private hospitals, only then this scenario arises.
I suppose you'll have to use our discretion if you come across a patient who's very ill to the emergency department, for instance, or by retrieval transfer from some other hospital. Obviously, you will have to take care of them if they are not actually in a condition to be transferred, like patients who require a high level of ventilator support, high FiO2s, whom you really cannot transfer safely. You may have to, my personal feeling is that we may have to handle it. We may not be able to transfer them. That's in fact included in our planning at this point of time. There is no clear directive from the government on this, as far as I can understand.
Okay, sir. Thank you.
Dr. Jose, we have some more questions from the online. So
Sure.
I would like to read out Dr. Pavan Kumar.
Sure.
Can it be possible to make negative pressure room in Indian hospital scenario?
It is very simple to do. I think you just require a very powerful graded suction to be attached to the room. If it's a single room, it's fairly easy to do. But if you need a whole area, it may be very difficult. In fact, our engineers, they're actually, they suggest that they're able to do it within a couple of days to make a single room negative pressure, particularly for doing nasopharyngeal and throat swabbing, which may generate aerosols, as I mentioned, and may require negative pressure. But over a large area, it is not easy to do. And given the short notice that we have, it may not be a viable option. But of course, in case you don't have negative pressure rooms, even in more developed health systems than ours, people are compelled to use normal rooms, normally air-conditioned rooms, and not really being able to use negative pressure in all instances. It may not be possible because it depends on the number of cases you come across. And if it's a huge number of cases, how do you really facilitate so many negative pressure rooms? It may not be viable at all.
We have the second question. Maybe that's a common question. I'm going to a third one. Dr. Raviraj Singh, what is the difference in viral load in symptomatic and asymptomatic patients? Because COVID-19 is also highly transmitted by asymptomatic patients right now, according to latest data.
I'm not entirely sure about asymptomatic transmission. Initially, they said transmission by asymptomatic carriers is very minimal or very rare, but maybe things have changed. The understanding has changed, perhaps. Maybe asymptomatic patients can carry the virus and transmit it as well. As to the viral load and transmissibility, I really have no clue. Perhaps somebody else can enlighten us on that.
This is a question from Pooja Murthy. The guidelines from WHO and CDC is different for PPE, especially for masks? Who recommends N95 only for aerosol generating procedures, unlike CDC, which guides to use N95 even for droplet? What is your hospital policy?
Our policy, thanks Pooja for that very important question. Our policy, if we are, as I mentioned, if we are involved in an intervention that is very well known to generate aerosol formation, such as doing swabbing for testing or doing laryngoscopy, intubation, NIV, nebulizations, etc., we would offer our staff N95 masks. But if the possibility of aerosol generation is very low, then we, like, in many patients in the ward, for instance, if we come across a situation wherein we need to treat patients in the ward as well, in that scenario, obviously, there is a huge shortage of N95 masks. Even normal surgical masks are in short supply. So obviously, you won't be able to use N95 masks as freely. You may have to confine it to procedures or interventions that require protection against aerosol formation, which will include most ICU procedures. So ICU, I think it makes sense. It is part of the personal protective equipment you must wear in an ICU setting. I feel strongly, if I'm asked to take care of a patient with possible COVID, I would insist that I have the full PPE, including N95 masks.